I'm going to say something first of all, actually, which is if you look at me and you look at Carey, you'll see that we were obviously of one mind.
Yeah.
It reminds me that when I first went into the sixth form at school and we were allowed not to wear uniform, I used to phone my best friend every morning to check what each other were wearing. And I just thought, in future, Carey, you and I need to phone each other before we have the same speaking engagement. Anyway, I'm going to talk to you today about our experience, our story within the Family Nurse Partnership of learning from evidence to improve services in the real world. And I've got a number of key messages, really, which I'll tell you and then keep returning to them. So first of all, I want to be really clear about the importance of using evidence well. I want to talk a little bit today about the challenges of complexity and context when you're measuring or evaluating in the very real world in which we all find ourselves. I want to tell you the story about how we're using evidence to improve FNP and also as well as to prove how some of the changes that we're making will make a difference or not. And then for me, there's a really strong underlying theme of collaboration. So they're all things that I'd like to bring out today. Before I go into the story, I just wanted to check how many of you know very much about the Family Nurse Partnership. Would it help if I give you a very quick précis? Okay, so it's an early intervention programme, structured, licensed. It is offered to first-time vulnerable, historically teenage mothers and their babies from early in pregnancy until the babies are 2, and a specially trained nurse visits them during the whole of that time with the aim of improving antenatal outcomes, child health and development, and the mother's own life course. And we brought it from the United States 10 years ago, actually, very shortly, to this country on the basis of the very powerful evidence for short and long-term outcomes, and because of the way of working, I think, as well. So I just want to start by saying that evidence is in the DNA, if you like, of the Family Nurse Partnership. It's based on sound theory. I was interested to hear you mention the Bowlby room, I think you talked about. So it's based on attachment theory, on human ecology theory, and on self-efficacy theory. It has a background of US trials. Nurses collect data about delivery, short-term outcomes, and client characteristics in real time to inform their practice. And we've conducted various evaluations within this country since we've brought it in. Most recently, we had the results from a randomised control trial. Last year they were published, which showed mixed findings, no evidence of impact in the primary outcomes, but a clutch of interesting findings around statistical difference, significant differences in child development, and some interesting things around safeguarding and maternal self-efficacy. So my story, my presentation really tells a story of what happens after that. So I suppose I first wanted to start off by saying there's quite a common view of evidence, which is that it's linear. It's there to measure things in quite a linear way. And it's very much about achieving a specific goal at a specific moment in time or not. Okay? And linked to that, I would say there's a very common similar approach to service design, which is that you can design things in a straightforward way, although it might be complicated. So you'll see here there's some iteration going on around here, and that you can plan the kind of outcomes that you're looking for. I think that while this is often what we think should be happening when we design services and when we try to evidence them, I think we all know that quite often this isn't what's actually going on. And one of the reasons is that there's a lot of complexity underlying what actually happens, particularly in very complex, developmental, socially constructed work. So I think you maybe would have seen this before. It's kind of, you have a equation at the beginning, and then the miracle occurs in the middle, and then you kind of get your outcome that you want to. And I think what we've been trying to do is to find out what lies underneath that miracle. So I've mentioned complexity a bit, and by that what I mean is that I think we all know that when we're delivering a program or delivering a service or acting as a practitioner, we're engaging with very different, unpredictable human responses. We're working in systems with individual organisational barriers and cultures. There's always the impact of what's going on in the rest of the world. So the politics, the economy, I think that we're obviously particularly aware of that right now. And then also there's just some kind of small and very practical things that can happen, like the IT goes wrong or somebody goes off sick or something. So when I'm talking about the kind of the real world, the messy real world or complexity, that's what I mean. So we can have a linear view, we can know what we ought to do, but that's not necessarily what happens. So actually when what we're measuring is often really, really messy, or it doesn't have very well-defined boundaries. Or, and this is an FMP client and her baby, there's something unfathomable and possibly difficult to measure going on, which actually produces the outcome. So there's something about the relationship between two people, between a client and her baby, which is often mirrored by or often modelled on the relationship between the nurse and the client, where it's more difficult to, it's not impossible, but it's more difficult and it's more subtle to explore what's actually going on here. So another way of illustrating this is the obesity map, which some of you may be aware of, and I'm just using this really to illustrate my point. So this is qualitative mapping. It kind of shows how something very complex and social, if you like obesity, is a result of interplay between a wide variety of factors. So some of them are about individuals, people's physical makeup, some of them are about their behaviours, some of them about physical activity, and some of them about what's going on in industry and in the political climate. And the benefit of thinking about things in this way and actually setting things out in this way is it helps us to kind of show what somebody called the inescapably systemic and messy nature of, in this case, obesity. I would say the same applies in many early years, early intervention programs or services. So we have a complex system. I also want now to say something about context as well. So this slide just helps us, reminds us that there are many, many different ways of seeing the world. So in FMP, where the programme is being delivered in over 100 local authority areas, and we all know that what's a priority in one area may not be a priority in another. We all know that populations are different from place to place. We know that the demography is different from place to place. And we also know that, I would say possibly increasingly, services are very, very differently constructed in different places, differently funded, and also they have different interrelationships as well. So we have we have very different contexts in which one thing can be delivered at any one time. So we've talked about complexity, we've talked a little bit about context. I want to say something about kind of overall context. I want to say something about the context in which we find ourselves in FMP right now. So this is, if you like, this is our real world. So we have lots of positives. We have a passionate, highly skilled, committed national workforce that's quite substantial, delivering in over 100 areas. Really high levels of engagement with vulnerable families who traditionally haven't always engaged with services. And that's something about the respect and the engagement that they find personally with the programme. Continued commissioner commitment, experience of delivering an evidence-based programme at scale for nearly 10 years. And what I think is really important is an infrastructure which allows rapid feedback, both from clients to us leading delivery, to practitioners and to policymakers, and then back again, which has really been very, very helpful. However, at the same time, we've faced a perfect storm, if you like, of funding cuts over the last few years, both locally and nationally, a shift to local authority commissioning, which in many ways has been fantastic because it aligns very much our priorities and what we do with local authority priorities, but clearly it comes at a difficult time, and it means creating new sets of relationships, and then mixed RCT findings, difficult, challenging RCT findings. So there are real positives, there are real assets, real investment, and there's also real need. So at recruitment, 46, onto the trial, the recent trial, 46% of young mothers had been suspended, excluded or expelled from school, 71% had truanted, 40% went on to experience domestic abuse, and 56% smoked throughout pregnancy. So this is a group of people who need a service to engage with, to support them, to improve their outcomes, and there are many other similar groups out there. So the need is still there, and we exist in a kind of in a world which is complicated and complex. And we felt that we didn't have the full story. So although it was tempting to take a black and white position when we received evidence and to think about, well, we either can deny it, we can say, well, this doesn't tell us everything, we don't believe it, or we could say, okay, let's think about something else to do. And it felt that actually the place to go was in that kind of shades of grey, was to really think about the assets that we had, to reflect very hard on the challenges that we had from evidence about where we needed to improve, and then also to use the assets that we had to actually try and build and do something different to improve, rather than to simply respond to proving, I think. So that means improving what we do already, but also working with local areas to do that. So our first steps were to really inquire more deeply, to deepen our understanding about what the trial told us. So we did some deep dives into smoking and subsequent pregnancies. And we tried to get a full picture. We reviewed our own data. We looked at the literature and the evidence, and we conducted focus groups with clients and with nurses to find out what was under the skin of this. How can you change, how can you change practice? What behaviours are happening here? What are the contextual factors which might influence what people are doing? So we wanted to kind of understand what it is that drives outcomes. And then we also, at the same time, felt it was really important to understand what stakeholders value 10 years on from bringing FMP to this country. So what is it that the people who commission, deliver and experience FMP, so including clients, want in 2016 in a very different world to 2006. And the kind of things they told us were that they were interested in child development, they were interested in safeguarding, they were interested in perinatal mental health, and in maternal health. So on the basis of this information and ongoing inquiry, we began to develop an approach which we felt gave a multiple response to a complex environment using the assets that we have. So our kind of high-level goals were really to improve cost-effectiveness of the programme, to improve impact, and critically, I think, to improve flexibility. So to ensure that it was as responsive as possible to the needs of both the service users, to practitioners, and also to local stakeholders and commissioners. And we wanted to do this while still retaining a kind of methodological and evidence-based core. So so that was our they were our guiding principles, if you like. And the four pillars of the work that we've done were to introduce, where we could, to introduce some universal improvements immediately. So we changed the eligibility criteria, we issued new guidance on smoking, nutrition, etc. We thought really hard about how local areas can take ownership of the impact and how they can understand the data that I mentioned before, and use that really well. So we've done quite a lot of work around local audit, data visualization, helping data to be accessible to support quality improvement, essentially. We then developed a programme that we called Knowledge and Skills Exchange, recognising that services need to integrate and support each other really well, whereby we developed learning packages in FMP, in areas of FMP knowledge and methodology that could be shared with other services, and where family nurses can train other professionals to be able to do that, and they're on our e-learning platform. And then finally, and this is kind of running towards the end of my presentation, we've developed for more difficult and complex changes that we felt we needed to explore in more depth. We've developed the ADAPT programme, which stands for Accelerated Design and Programme Testing, in 11 sites. And with those sites, we're co-producing with them a series of both clinical adaptations to the programme, so looking at different ways to quit smoking, to address domestic violence, to think about maternal mental health, for example, continue breastfeeding, at the same time as developing what we call personalisation with FMP. So I talked about a structured programme. It will still be structured, but it'll be more flexible, so there'll be far more options to increase visits or to reduce the number of visits, to leave the programme early, to change content, all based around a conversation, a structured conversation between the nurse and the client, with an assessment using the outcome style, which some of you may be familiar with. So personalisation is a really central part of our work going forward. And doing that work, we're gathering data, both qualitative and quantitative, on a 3-monthly cycle. So we're borrowing from improvement science, really, to design, test, look at what the tests tell us, and then iterate and then rapidly test again. So working on 3-month cycles, because I think we all know that right now we need to be able to respond very quickly to what evidence and what the context is telling us. And this is a diagram of we've tried to make it simple, but this sets out some of the way that we've attempted to take account of both complexity and context. So we're doing the work in consultation with many other people. We're doing it on a cyclical basis. We've retained evidence at the core by thinking about logic models, dark logic models, which are basically unintended consequences, thinking very systemically about contexts, and gathering data. And that's really all I wanted to say at the moment. But I wanted to leave you with some final thoughts, which are really around our experience of working with evidence. And I would say that there's something really important about accepting challenge and the need to improve. At the same time, not accepting just what you see on the face of it, but digging deeper, trying to uncover a bit more, iterating, and then embracing failure where necessary. And then co-production or collaboration, working with families, working with commissioners, and working with practitioners to create and innovate together. So, thank you very much.